Thanks, Kamal. Good morning, ladies and gentlemen. We had a very short discussion. Those of who were here yesterday would remember about the problems in instrumenting the osteoporotic spine. So I will focus on this in my talk today, and after introduction of the fixation problems, I will focus on the preoperative, intraoperative, and postoperative preventive measures to prevent failure of instrumentation in osteoporotic patients. Osteoporosis, as you know, may cause compromised bone strength, predisposing failure of bone implant interface. And one of the major complications of surgery on patients with osteoporosis is the fixation failure. And other than that, fractures of uninstrumented segments and increased deformity, which would not be the main topic of this talk, but maybe discussed in the discussion time, are the other problems. And increased deformity, especially due to fixation of failure and fractures of uninstrumented segments, may be a big problem for us. Preventing fixation failure in osteoporotic spine, in fact, starts with preoperative preventive measures. And we may have, or we may develop some strategies intraoperatively, and finally, postoperatively, we may have other preventive measures. And starting with the preoperative, especially the diagnosis, as you know, we should routinely have the only evaluation tool which may help us to develop intraoperative or preoperative strategies is the bone mineral density. And unfortunately, this is the only tool that we have in our hands. And the risk for implant failure starts with the osteopenic patients, which was described as the patients who has a bone mineral density between -1 and -2.5 standard deviations. And after 2.5 standard deviations, as you know, the risk is getting higher and higher. And there are some thoughts that for those patients who had over -3.5 standard deviation, the surgery may be contraindicated. And knowing the risks by using this bone mineral density, we have to have also a very careful evaluation of spinal column and especially the deformity. And then we have to discuss with the patients about the risks very clearly. One of the things which is important here, I think I should point here, is that the bone mineral densitometry may not help us all the time. Yesterday it was mentioned that we should rely on the hip densitometry rather than the vertebral bone mineral densitometry, as we may have some false good results due to the spondylosis. But even the hip bone densitometry may not help us or may not really reflect the real situation of the bone. So in this case, and especially in those patients who had or who is in the category of osteopenia rather than osteoporosis, the careful judgment of screw insertion torque strength during the surgery, which is empirical, but can be understood by the experienced surgeon, is very important. Increasing bone mineral densitometry by delaying the surgery may be one of the ways to prevent implant failure. But we know that even the best medical treatment may increase the bone density only by 6 or 10% after 1 year of treatment. And we don't have any scientific evidence or any data how much this 6 or 10% increase will affect the torque strength of our pedicle screws. And also most of those patients who came us for their pain and who, for whom there's an indication for surgery, in reality cannot wait for 1 year or more than that. So of course, if the patient has very severe osteoporosis, we should continue with the conservative treatment and put them on the osteoporosis treatment and follow the bone densitometry. But this is not very easy for all patients all the time. These are the preoperative measures. And how about the intraoperative measures? In intraoperative, there are two important things. One of them is to develop a strategy to maximize, enhance, or augment anchor points. And the other one is to be very careful while correcting the deformities, especially if the patient has deformity, and decrease demand on fixation for deformity correction. How can we do that? Okay, so the options that we have in our hands are screws, which we love to use, especially prefer for the lumbar spine, and then hooks and wires or cables. I want to start with especially with the pedicle screws. The problem with the pedicle screws in osteoporotic patients starts with the toggling. And due to the stresses and toggling, then the screws get loosened in the empty bone, and then it results eventually with pull-out, which is a big problem. And to prevent all these events, we have some preventive measures, and pedicle screw factors are among them. And regarding the pedicle screw factors, we should know the screw characteristics, and we should be very careful about the insertion technique, and I will talk on details. And also we should judge the bone quality, as I have mentioned before, and do augmentation if it's necessary. Regarding the pedicle screws, double-threaded screws, as seen here, has been shown to have a higher insertion torque when compared to the regular screws, and also presumably they have a higher fixation strength due to denser thread at the pedicle area. We have now them in the market, but we don't have the long-term follow-up results, clinical results with those screws. Depth of screw penetration, insertion angle, and hole preparation and tapping are the key features that we should be very careful during insertion of the pedicle screws. Regarding the depth of the screw, this biomechanical study has shown that 80% penetration when compared to a 50% depth of penetration increases the cutout load to failure at least 32 to 5%. And ideally, we should get maybe a bicortical purchase for the osteoporotic spine. This should be done, and this is feasible for S1, but for the other levels, of course, this may be dangerous. But the thing that we can do is to use as long screw as possible. Insertion angle in the lumbar spine, we can easily do paired screws in 30 degrees convergence for the majority of the lumbar spine, and this will add a pull-out strength more than 20, almost 30% when compared to the parallel screws. This is actually what we do also for the other patients who has no osteoporosis. But for the thoracic spine, again, the insertion angle, especially medialization, may be important. And this can be provided only if we use the pedicle rib screw technique, which is called also as the in-out-in technique. And by this way, we can medialize the pedicle screw, and also we can use larger screws, as we will have a larger effective diameter when compared to the pedicle screws through the pedicle. The other important factor is the insertion angle or trajectory, and this study has shown that when we use the straight forward technique compared to the anatomical trajectory, which is shown as blue here, with the straight forward technique, we will have at least 27% increase in the pull-out strength compared to the anatomical technique. So this should be preferred in osteoporotic patients. Regarding the hole preparation, as you know, we may either use drill bit versus probe, which I usually prefer. And this biomechanical study has shown no difference in the pull-out strength with both techniques. But the most important thing here is we should not penetrate the pedicle cortex, because when we penetrate the pedicle cortex with either technique, pull-out strength is decreasing by 11%. And I would also like to take your attention about not to use a large diameter of screw. We know that in osteoporotic spine we should use as large diameter as possible, but we should not use larger diameter than the pedicle diameter, because if you break the pedicle, then we will have almost no or very less pull-out strength. Tapping osteoporotic bone has been discussed several times, and in this paper it has been shown that if we tap the osteoporotic bone with the same tap size with the pedicle screw, we may decrease the pull-out strength by 8%. And also this study by Kuklo has shown that when we tap the pedicle screw with a tap which is 1 millimeter smaller, narrower than the original screw, we will increase the pull-out strength at least 47%. And tapping the screw, pedicle screw, is my preferred method because it also gives you, or it increases safety where the pedicle screw will pass through. Otherwise, you may find another tract, and you may easily penetrate the medial cortex in the osteoporotic bone. So I prefer to tap, but I prefer to tap at least 1 millimeter smaller tap size. To summarize the pedicle screw insertion strategies, straightforward technique seems to be better. We have to use pedicle screws as long as possible. Medialization may increase pull-out strength. We should not penetrate the cortex while preparing the pedicle screw. And under tapping may help to increase the pull-out strength of the pedicle screws. And one other thing that might be helpful to prevent the pull-out of the pedicle screws is the hook supplementation. And this study has shown that when we supplement the pedicle screw at the same level with a sublaminar offset hook, we may increase the stiffness for the short segment pedicle instrumentation, or we can increase the pull-out strength for that pedicle screw. Crosslinks, on the other hand, with the medialization in the lumbar spine, we believe that especially for short instrumentation, we may not need those crosslinks. But it's not the case in the osteoporotic spine. So crosslinks really help a lot in increasing the stability of our construct. And I usually prefer to use at least 3 crosslinks when I do a long fusion from T2 to sacrum. The augmentation is the last effort actually to increase the pull-out strength of our pedicle screws, and it may be necessary especially in osteoporotic spine. And many studies have shown that especially in osteoporotic spine, when we do a cement augmentation, we may increase the pull-out force with a very considerable amount of Newton force. So this study by Mayput from Minnesota has shown that pull-out strength has been increased at least 70% in the thoracic spine when augmented by the cement augmentation, and this increase has been found to be 120% in the lumbar spine. In this study, cement volumes has been determined as to be at least 0.5 cc in the thoracic spine and 1 cc in the lumbar spine. And one of the interesting points of this study was that excessive cement volume does not provide increased pull-out strength, which I suspect a little bit. We have in our institute, we are using cement augmentation very routinely, I would say, in almost all osteoporotic spines, and we have published our first results in this paper in Journal of Spinal Disorders in 2009. And now we have recently evaluated our first 130 patients who had more than 2 years of follow-up, where we used the pedicle screw augmentation by cement, and we will present this paper in the SRS this year. And the indications for those patients was those patients who had BMDs minus 2.5, and for the osteopenic patients who were between minus 1 and minus 2.5, we actually decided whether to augment the pedicle screw with cement according to insertional torque strength that I have mentioned before. And in our technique, actually, we prefer to inject at least 4 cc's in the lumbar spine, 3 cc's in the thoracic spine, and 2 cc's in the upper thoracic spine. And one of the techniques that we are using to prevent the increased pulmonary wedge pressure and also the increased risk of pulmonary emboli, we aspirate through the cannula. We do a mechanical aspiration through the cannula, all the bone and bone marrow inside the vertebral body before injecting the cement. We have shown in a study that this really helps a lot to decrease the pulmonary wedge pressure. So at the end of when we evaluated those 1,454 pedicle screws, we haven't seen any screw loosening, pull-out, or migration, or pedicle screw related complications. But we definitely had cement emboli in 8 patients, where 4 of them had respiratory problems. But we didn't have any deaths, and we had acute hypertension in 18 patients, cement extravasation in 27 patients. Thank God we didn't have any neurological problems at the end of this procedure. So this procedure is a little bit risky. We have complications with that, but I think it saved our lives by preventing also the complications related with the pedicle screw pull-out or instrumentation. This is a typical patient who had a 4-5 spondylolisthesis and also 1-2 burst fracture, which compromises canal, and the patient had also neurological compromise. And we did decompression at the L1 level, and also we did anterior and posterior fusion with the augmented pedicle screws. And in those patients, we routinely also augment the adjacent non-instrumented vertebra, 1 or 2 vertebrae. This is very empirical approach. Again, we don't have clear-cut indications for that, but we routinely augment with cement the adjacent non-instrumented vertebra in those patients. How about other anchor types? We know that lamina has an increased cortical bone and also larger contact surface and may be more suitable for instrumentation, especially in the osteoporotic spines. And we may either use wires, hook, by making claws or dacron bands. And the benchtop biomechanical studies have shown that screws had poor strength when compared to the hook claws in the osteoporotic spines. But in our daily practice, especially in lumbar spine, we still prefer to use pedicle screws. And the last thing about the intraoperative strategy is the degrees demand on fixation. This can be done by enhancing purchase of internal fixation and increasing the number of the anchor sites. And also we should be very careful, especially to protect bone implant interface from stress while doing our correction maneuvers. So we need extensive release for instrumented deformity correction. We should preserve end plates for anterior structural support, and we should definitely maintain sagittal alignment and lumbar lordosis, especially to prevent the junctional failures. And finally, what we can do post-operatively, decreasing the activity for those patients and also immobilizing them by using some external mobilization tools like the braces, and also giving those patients isometric exercises and activity to strengthen the muscles may help us to prevent failures of instrumentation in the osteoporotic patients. So to sum up, fixation of osteoporotic spine is really very problematic, and we are doing more and more difficult surgical cases where we may need instrumentation from T2 to sacrum in those very old patients. Prevention should be the main goal, and if we rely on the basic principles that I have mentioned in my talk, the instance of problems may decrease. I don't say that we will have no problems, but we may have less problems. And in our practice, it looks like cement augmentation, although causing some severe complications, seems to be helpful. But this topic seems definitely will keep us busy in the future. Thank you very much.
Thank you, Ahmed. Stay there.